Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we are exploring infertility evaluation, history and diagnostics. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. Their world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. Dr Genia Rozen is a senior clinical lecturer and clinical school tutor at Melbourne University. Dr Rozen is involved in the fertility preservation service at Genea and Royal Women's Hospital in Melbourne. What key elements should be included when taking a comprehensive fertility history for both male and female patients?
So when taking a fertility history from a couple, it's really important, first of all, to address the couple, because both the male and the female are very important. And if we had to sort of divide up, infertility causes, it goes about third. So 1/3 of factors being female, 1/3 male, and a third of cases would have a combination of both male and female. So it's really important not to forget the male partner. And sometimes we have patients rocking up without their partner because they don't think it's important to have the male there. So that's a really important thing, a significant thing to stress right up front. The next thing that is important to address is what actually have they been doing? What has trying meant to this individual couple? And we uncover a lot of important factors right from that point onwards, because the trying is, it's about finding out for the female the regularity of her menstrual cycles, and if her cycles have been very irregular, infrequent. So number one, finding out menstrual history. Does it sound like she's ovulating, and when are they actually trying? So if she does have a regular cycle in that fertile window, have they actually had sex a number of times every second day, roughly, so about 3 times in that week? Have they actually hit those times? And it's amazing what you can uncover at that point. So the next thing is we want to find out more information about her gynecological history. So that's things about her uterus, tubes potentially. Has she had a pelvic ultrasound? Has she had her tubes checked yet? Are there any risk factors for having blocked tubes? Is there a suggestion of endometriosis, which might cause a disruption in the anatomical factors of her pelvis? And then health issues, so medical conditions that can interfere with fertility, or potentially medications, the treatment of those medical issues that again might impair things. And then lifestyle, important to find out about smoking, alcohol, diet, exercise, weight, and then also what are their expectations, what are they planning for in terms of family size. That often will colour or, somewhat change plans if they're, for example, planning a very large family and combined with a couple age, versus, only having one child, etc. So that's for the female. The male, you'd be wanting to know about the male's medical history. Is there any history of urogenital infections, testicular trauma? Is there any family history of genetic conditions? And then, of course, the male lifestyles, that's smoking, alcohol, diet, exercise, and, of course, weight as well. And has the male had a semen analysis yet? Probably at the point of the primary healthcare provider that the male hasn't yet had a semen analysis, and that would be one of the first primary tests to order.
How can GPs effectively gather information about lifestyle factors such as diet, exercise and stress that may impact fertility?
Yeah, so I think getting that information is so important, which is why, for example, when I see couples, the consultation is really quite long, because there are so many different things, different, themes in the couple's history for both the male and the female that we have to unpack. But what's also important, I think, is that things like diet, exercise, they really impact health overall. And we shouldn't be viewing the reproductive system as its own little subplot. It's part of our whole body's health and well-being. So GPs would regularly, they'd be used to asking about dietary factors, exercise, as part of, their questions for any health condition that the patient might present with, and it's no different in this area. Stress is an interesting one because I often get asked about stress. So it's often not me asking the patients about stress, but them asking me, is stress playing a role? Might the stress that I'm under be having impact? So in other words, a lot of our patients really worry about what effects their stress is having. And it's important to acknowledge that stress is a part of all of our lives. There's very few of us who walk around with no stresses whatsoever. And really, it's more about, what you put into what they put into their day, having pockets of time for exercise or mindfulness, or, what they put into their day rather than what they take out. Like quitting their job, or things that are quite unrealistic to life changes to make. Whereas doing additional exercise, improving, which has so many benefits, improving blood flow, antioxidants, all those things that exercise can do. It's about them hopefully finding ways to incorporate that into their life.
What should doctors be asking about a couple's duration of infertility and previous attempts to conceive?
Yeah, so as I mentioned first up, I think that's quite an important question, to figure out what level or degree of infertility exists. So, for example, sometimes a couple will say they've been trying for 6 months, but when asked about previous contraceptive use, it actually turns out that they haven't used contraception for 5 years. And then when you further ask questions about, well, what have you done to avoid falling pregnant? They might say nothing at all. And then you ask them further about their sexual history, how often they have sex, and it kind of sounds like they actually have been having sex in that fertile window once or twice, probably each cycle, just naturally. Now, that turns very much from a case of trying to conceive for 6 months to actually, we're talking about a infertility duration of closer to 5 years. So that's where finding out about their previous, what's actively trying versus passively trying or not trying at all, if they're actually having still sex at the right time and not using any contraception. So that's an important little nuance to unpack there.
Are there any red flags in a patient's medical history that might prompt an earlier referral to a fertility specialist?
Absolutely. So for the female, having irregular cycles is a reason to refer someone straight away, for example. So while we consider infertility to be trying for 12 months and not being successful, in fact, that's assuming that someone has regular cycles and is trying to conceive in the fertile window. Now, we know the reality is that a lot of our patients, A, don't have regular cycles, and B, aren't trying to conceive necessarily in the right times within that cycle. So if either of those criteria are not met, or patients are unsure themselves when to be trying or need a bit of extra advice about the fertile window, that's a really good opportunity to either, if you are comfortable having that discussion and spending that extra time with the patient to go through that, or referring them to a fertility specialist. Because, of course, referring a patient on doesn't mean, and this is where we have to sort of educate patients, that it doesn't mean that you're going to have IVF offered to you as something first up. There are often a lot of other things like tests that can be done, and little things that can be optimized in order to help them achieve conception in a minimally assisted way. So those factors like the periods and not trying in the right time would certainly be red flags for earlier referral. Then there are other things, for example, previous history of cancer for which they might have had chemotherapy, things where you might be dealing with a shortened fertile window, compared to what's, what the average is. And equally for the males, if they've had previous, undescended testes, testicular torsion, or they've had chemotherapy or other, radiation treatment or something like that for cancer, then they're more likely to have a problem, which may need more help addressing. And so you wouldn't just, wait 12 months to be evaluating them, to probably to start off with a semen analysis in that case, and then see what it shows. The other red flag would be a couple where their medical conditions or the treatment that they're having, the medications, where they may not be safe for pregnancy. They might, for example, be on Ozempic to lose weight. There are things that, and they shouldn't really be trying for pregnancy before going off it. So there are things that kind of need to be thought about or planned for. Sometimes we send them off for obstetric counselling as well to talk about extra plans in pregnancy to be put in place. So that requires more thought prior to conceiving.
What initial diagnostic tests should GPs order for male patients, and how can they interpret these results?
So for male patients, the main test that we really want to see is a semen analysis. Now, we just have to remember that a semen analysis, that the results of a test don't necessarily reflect fertility, in the sense that if the parameters are within normal range, it doesn't necessarily tell us that there's no male issue or that they're fertile. If there's an abnormality where a parameter is outside of the reference range, it equally doesn't indicate that the male is necessarily infertile or going to have trouble conceiving. It's not a functional test. It doesn't tell us about how well the sperm is able to fertilize the egg, etc. So there are certain limitations to the test to begin with, but it is a really great and easy diagnostic screening tool. So we always like to do that for our male patients. And the other one is screening blood tests. So we do infection screen like hepatitis B, C, HIV. We also like to exclude STIs for the male. We can test that in the urine. And we also sometimes do a karyotype chromosome test right up front.
What are the appropriate initial diagnostic tests for female patients, and when should they be ordered?
The timing of starting to evaluate for infertility, if we have to sort of develop rules of thumb for it, would be, and depending on how much anxiety or pressure the patient present with in the first place, that might alter that rule of thumb timing, because every presentation, we really have to think about individualizing it. But in general, for a young couple, so where the female age is under 35, we'd be starting investigating after 12 months of trying, and after 6 months if the woman is over 35. If there are any of those red flags present that we discussed before, like irregular cycles, then that would be straight away without waiting any time at all. In terms of the female test that we'd want to know, so number one, so in general, we'd break up the main sort of investigations into a few themes. So number one would be the general pre-pregnancy or pregnancy screening test. So that's things like infections, they're immune to chickenpox, rubella, checking their iron stores, and I would include AMH as a part of that as well. Although some primary care providers are more comfortable with interpreting or giving patients the AMH results. So if someone feels less comfortable to do that, I don't think it's an issue. And I'm always happy to order it when I see a patient in my rooms. The other testing that we would want patients to be offered is the genetic carrier screening. So that should be information given to patients about the 3-gene panel, which is now Medicare subsidised or paid for, as well as the options for expanded panel. So the over 600 odd tests that are available for couples to have screening. Ultrasound, that's an important part of the workup to look at uterine or pelvic anatomy, also the antral follicle count. And sometimes tubal patency testing will go along with that, but sometimes it won't be as relevant. So it's not necessarily something that has to be ordered straight away. So they're kind of very useful tests for us to have, the results of which to have when we're seeing our patients for the first time.
When is it appropriate for a GP to refer a patient or couple to a fertility specialist?
There's lots of reasons apart from actual specific fertility indications for referring a couple. But in general, again, the rule of thumb for referrals is for a younger couple after 12 months of trying, if the female is over 35 after 6 months of trying, if there are red flags, then straight away, potentially. Then there are other sort of different indications. For example, there might be a couple who are both carriers for a certain genetic condition, and they're wanting to avoid or reduce the risk of transmitting that condition to offspring. So that would be a reason to refer a couple to a fertility specialist straight away for that planning. There might be a same-sex couple who need donor gametes to conceive. Or, for example, fertility preservation. That's an area that I work in a lot. So someone who has been diagnosed with cancer, and that would be a reason to refer someone straight away to discuss fertility preservation.
What are some common misconceptions or overlooked factors in the initial evaluation that a GP should be aware of?
So I think number one, that digging deeper into how long they've actually been trying for and what that's looked like, because it may not be quite what it seems. Other things are related to AMH. Patients are often very alarmed when they get a result that looks a little bit lower than average, and a misconception there is that the AMH is a fertility test and it indicates that their fertility is less than average. And I spend a long time talking to my patients about what the AMH actually can tell us about, etc.
How can GPs support patients emotionally during this initial evaluation stage, especially if test results are not favourable?
So I think that that's probably one of the key things, and it's something that I think we all can do better. This is an area where patients feel, it's a really huge part of their lives, what the fertility troubles they're experiencing. And it can almost, from studies that have been done in this area, patients report that having infertility is, as distressing to them as having a death in the family, for example, a trauma like that. And I think sometimes we, as well as miscarriage, the distress experience with miscarriage. And I think sometimes we can really underappreciate how much our patients are affected by it, and therefore, especially with miscarriages, because of how common they are. So I think knowing what supports are available, offering patients additional appointments, trying to understand the experience that they're going through, whether they're seeking more information, or how best reaching out to them, see how best they can be supported psychologically. I think those things are really, really important. We know that even when patients start their IVF journey, there's a high, significant proportion that drop out before they achieve pregnancy because of a lack of psychological support. So I think in every step of this kind of journey in this area, I think support is so important. And that's where also connecting, for us as fertility specialists, I think we really need to be giving a lot of information to our GPs about their patients, so that we are all on the same page about where they're at. Because often patients, I think, will see their trusted GP provider even while they're having treatment to kind of talk about their experience. And if the GP understands what they're going through, where they're at, I think that can help a lot. So better, clearer communication between specialist and GP, I think that will really help our patients as well.
Could you provide an example of a case where early intervention based on the initial evaluation led to a successful outcome?
The story that comes to mind is I have had a couple of these patients over the years. So where a woman's come off the pill in order to conceive, she's been on the long-term pill, and her periods are irregular. Now that's not, that doesn't sound like something so unusual or worrying. But in some of these cases that come to mind, it's actually they've got a really low ovarian reserve. The reason they're having irregular periods is actually because they're running out of eggs. And early referral can really make the difference between them. If we can do some cycle tracking for them, if we can do whatever sort of level of treatment they need. We only have a small window of time before they run out of eggs. And if it's not picked up that the reason their irregular cycles are actually because they're running out of eggs, but it's like thought, it's still regulating post-pill or whatever, if that's missed, we really can run out of time. So I've had patients who, we've been able to either with them with some cycle tracking or even with IVF, being able to get sort of like one egg where that turns into, one embryo, one baby, where that window was really very, very limited.
Thank you to my special guest, Dr Genia Rozen. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. Their world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.